Thank you, Kim. Okay, let's see if I can figure this out. All right. So thank you for the opportunity to speak with you about incarcerated ventral hernias, and I think we have to really highlight the word incarcerated, okay, because there's lots and lots of data about elective ventral hernia repair, very, very little data, as I'll show you, about incarcerated repairs or incarcerated hernias and using laparoscopy. I have no disclosures. I was always taught, and I always teach my residents, never say never or always. I'll show you that there's essentially no data of value to help us discern what is best to do. Again, incarcerated, not just a ventral hernia. And I'll try to give you a common sense approach about how to potentially think about these types of dilemmas. So why do I say the existing data is not very good? So there's large studies, no doubt, very large studies. I'll even show you one of them. But they're not trials. They're predominantly based on NSQIP data, and as we heard already, this is inherently flawed by the selection bias. I will show you a reasonably sized controlled trial. However, there's either no or very few incarcerated hernia patients in this trial, so it's a little bit hard to tell which way we should go. So this is the largest NSQIP type trial. Again, these suffer from selection bias. Over 100,000 patients compared laparoscopically to open approaches. On the left, you see 32, almost 33,000 patients that were incarcerated, okay? They don't tell you anything other than they were incarcerated. 3/4 of them were done open. And as we've already heard, the morbidity and length of stay was significantly higher in the open group. They then tried to distill this down a little bit more, took a matched group of patients from demographic, age, and other types of match criteria. Not surprisingly, 50-50 open versus laparoscopic. And again, we see that the laparoscopic approach had lower morbidity and length of stay. But again, I push that these are inherently flawed studies because of the selection bias. We don't know what made a surgeon choose an open versus a laparoscopic approach. This is data from Todd Henneford, a name that I know is well known to this group. This was using a different NSQIP type of database. This was an international hernia registry and looking at quality of life. And interestingly, the conclusion showed that laparoscopic ventral hernia is associated with a decrease in quality of life in the short term. And again, we see that length of stay and infection rates are decreased with laparoscopic approaches. Overall complication rates remain equal. So as I said, there is a number of studies. I'm just going to quickly go through some of these titles that talk about the benefits of laparoscopic surgery. As I said, all of these are flawed by selection bias. So what about a randomized clinical trial? Here's one that is, I believe, but I could be wrong, the largest randomized trial. 206 patients randomized, about 100 in each group, randomized to open versus laparoscopic repair. Not surprising, operative time was a little bit longer in the laparoscopic group and had less blood loss in the laparoscopic group, and nearly 8.5%, 9% conversion rate. So I think if we're going to talk about a randomized trial where you don't get to choose which is the good patient for laparoscopy, those rates of conversion are higher than just a small percentage. If we look at the small bowel injury, enterotomies, they were significantly higher in the laparoscopic group, approaching 10%. Again, when you don't get to choose your patient, you're going to have higher complications in the laparoscopic group. Not surprisingly, though, the wound infection rate and the like was higher in the open group. And then recurrence rate, obviously shown here, there was really no difference in outcome. This is the most recent trials that I could find that were randomized, the so-called ProLove trials, initial report in 2013, a subsequent report in 2016, again looking at open versus laparoscopic repair. And unfortunately, this is a little bit not so useful, because if you look at the preoperative complaints, no one is actually incarcerated, the best I can tell. Some might have had incarceration episodes. And even if all these patients are incarcerated, we're talking about 10 versus 13 patients. So I don't know that that's going to really help us decide which path we should choose, open versus a laparoscopic approach. If you look at the data here, surgical site infections were higher in the open group. Bowel injury was higher in the laparoscopic group, but it didn't approach significance because of the relatively small numbers, 64 and 69 in each group. And overall, you can say there was potentially a benefit in the laparoscopic group, is that 85% had an event-free recovery versus 65% in the open group. So one other thing to bring up, that I know this is becoming a bigger question, is an onlay intraperitoneal mesh the way to go, or should we reapproximate the midline, and does that lead to fewer recurrences? Here's one small study published last year, 82 patients, 40 patients had just an onlay intraperitoneal mesh versus 42 that had onlay mesh plus closure of the midline. And you can see all the recurrences occurred in patients that just had onlay mesh. So perhaps there is something to closing the midline. Not saying this can't be done laparoscopically, it can, but this is just one other piece of the puzzle that we have to try and figure out. So how do I think about this in terms of really not whether we should be doing laparoscopy or not, but is laparoscopy going to be feasible? Some of the things to think about is size. Quoted in the literature to some extent is defect. If it's larger than 10 centimeters, does that warrant an open approach? If it's real tiny, less than 2 centimeters, and you have something incarcerated, it's better just to make one small incision over that incarceration and deal with it. What about the volume of contents? Is there loss of domain? I think you need to consider whether or not the laparoscopic approach is really going to be beneficial in a patient with loss of domain. And then the other thing that I think we need to consider is what is the size of the defect versus the volume of the contents. If you have a relatively small-necked hernia with a large volume of incarcerated contents, you're going to have to open that defect a little larger. That's technically more challenging. Again, not impossible, but something to consider. What's in the contents of the sac? Omentum, all right, I would say have at it. You're probably not going to hurt anything all that much if you're trying to get omentum out of the contents of the sac. Intestine, on the other hand, you may want to think twice about diving into that. And if there's mesh stuck in there and the bowel's attached to the mesh, that also makes it difficult, and maybe laparoscopy isn't the best way to go. Finally, laparoscopic feasibility with regard to, is there an inflammatory response? Studies show that if there's free fluid in the sac on CT scan, that's a concern for already dead bowel. Skin changes are obviously concerning. And, some of those outliers where there's skin graft over bowel or an enterocutaneous fistula, probably not going to be the best ones to approach from a laparoscopic point of view. What's on the horizon? There's 2 prospective studies that are being done. This one out of Italy, looking at whether or not bridging versus closure of the midline is important in terms of recurrence. And then this one also, the INCH trial, is out of the Netherlands, looking at open versus laparoscopic approaches. I have not seen any data on these. Perhaps people in the audience have seen some abstracts at other meetings that I have not seen. So with that, I'd like to thank you and hope I made my point as to whether or not we should approach all incarcerated hernias laparoscopically. Thank you.